Dear colleagues, my name is Annieke Gotink and I'm a research physician at the Department of Gastroenterology in the Erasmus University Medical Center in Rotterdam, the Netherlands. On behalf of the co-authors, Dr. Yonne Peters, Professor Peter Siersma from the Radboud University Medical Center, and Professor Marco Bruno and Dr. Arjen Koch from the Erasmus University Medical Center in the Netherlands, I would like to thank Endoscopy for the opportunity to discuss a recently accepted manuscript entitled Non-Thermal Resection Device for Ablation of Barrett's Esophagus, a Feasibility and Safety Study. For the endoscopic eradication of Barrett's esophagus, several techniques exist. However, all have limitations regarding successful conversion to squamous epithelium and a complication profile. The endorotor is a novel device that has, thus far, shown promising results for the eradication of Barrett's esophagus. The endorotor is a non-thermal ablation device, suctioning Barrett's epithelium in a small orifice, where a rotating knife resects the mucosa, automatically collecting tissue for pathological review. Due to the lack of thermal or electrical ligation involvement, it is hypothesized that there will be a lower stricture rate and the procedure will be less painful compared to established ablation techniques. The aim of our study was to assess the feasibility and safety of the endorotor as a first-line ablation technique for the eradication of Barrett's esophagus. In our study, 30 patients with therapy-naive Barrett's esophagus were prospectively included in 2 tertiary referral centers in the Netherlands. Outcomes included the percentage of endoscopically visible surface regression 3 months after ablation with the endorotor and complications that may have occurred during follow-up. Our study concluded that the endorotor was able to ablate more than 90% of the Barrett segment in most patients. The percentage surface area that regressed after a single endorotor procedure was high, about 80%, with mostly small tongues and small islands remaining. This is comparable to RFA, where the percentage surface regression after a single RFA treatment is reported to vary between 83 and 90%. With regards to safety, however, results were slightly concerning. 2 serious adverse events related to the endorotor procedure occurred. 1 perforation and 1 post-procedural bleeding requiring a repeat endoscopy with intervention. These rates are higher than adverse events after RFA with or without prior endoscopic resection, and also higher than adverse events associated with cryotherapy, where perforation and post-procedural bleeding occurs in less than 1% of patients. We had hypothesized that the endorotor ablation would result in fewer strictures and would be less painful compared to standard ablation techniques due to the lack of thermal or cautery effects. However, symptomatic stenosis were reported in 13% of patients, which is considerably higher compared to RFA and also for cryotherapy. Post-procedural pain was reported in a majority, or about 60% of patients undergoing the endorotor ablation. Although this rate is comparable to RFA, cryotherapy seems to be better tolerated in terms of pain and dysphagia. Along with these safety concerns, the endorotor technique also harbored other drawbacks. First, operating the endorotor device was technically demanding, and at times there was difficulty in determining optimal ablation depth and completeness of the procedure. Also, endorotor ablation was more time-consuming than RFA and cryotherapy, especially for longer Barrett segments. Histological assessment of the resected tissue was of limited value, as this did not alter patient management. Based on these results, we do not recommend the endorotor as a first-line ablation technique for the eradication of Barrett's esophagus. Thank you for your interest in our study.